All right, good morning or good afternoon. Welcome to today's webinar. Sorry for the delay, we were having some technical difficulties today. My name is Michelle Needham. I'm the Chief Policy Officer at the Washington State Healthcare Authority. The purpose of today's webinar is to provide rural providers with an update on Washington State's proposed model for statewide rural transformation, and hear from other states on their approaches to transforming rural health. This webinar will be recorded, and the recording and slides will be posted on our Rural Transformation website soon. Before we get going, we'll just take a moment to take care of some of the logistics. All participants have been muted. If you have a question about the materials presented, please enter them into the chat panel. We will collect questions throughout the presentation and we'll address them at the end of the webinar. We'll follow up with those questions, and if we're not able to get through all of the questions, we will follow up with those afterwards. So for today's webinar, I'll be your moderator, and our presenters include leaders from the federal government, the Healthcare Authority, Pennsylvania, and Maryland. Rifkin Friedman from the Centers for Medicare and Medicaid Innovation, Rachel Quinn from the Washington State Healthcare Authority, Janice Walters from Pennsylvania Department of Health, and Mike Robbins from Maryland Hospital Association. In addition, we acknowledge that Shule Gurovich has also joined the webinar. Shule is a Mathematica senior researcher and expert on all-payer alternative payment models and total cost analysis. She has extensive experience with the state health policy in Maryland, Pennsylvania, and Vermont, and currently leads 2 projects to support Vermont's implementation of the all-payer accountable care organization model and Pennsylvania's rural hospital global budget. She'll help address technical questions on the global budget during the Q&A portion. As the largest purchaser of healthcare in Washington, sustaining access to essential healthcare in rural communities is a top priority for the Healthcare Authority, as well as for other public and private purchasers, like Medicare. Rural providers and health systems are a key part of the economic fabric and backbone of rural communities. As urban areas have changed, so have rural communities and their populations. With economic and demographic shifts, healthcare delivery needs in rural communities have changed. Along with meeting the acute needs of the community, there's a greater focus on health and well-being of the people served in these rural areas. Throughout Washington's rural communities, the state, rural providers, payers, public and private purchasers, local health jurisdictions, accountable communities of health, rural associations, and other community advocates must collaborate to redesign healthcare together in ways that work for the community, not just for one provider or one hospital. It's too big of an economic and social problem for just the Healthcare Authority and one rural provider to solve alone. Rural transformation has been a priority for the last several years for us, and we are encouraged that Medicare shares our sense of urgency and need to support our rural communities as they transition to new models of care. In May, there was an announcement from CMS on their rethinking of the Rural Health Initiative, with recent comments from Administrator Verma, and a new model specific to rural communities that will come out later this year. So we thought it would be helpful to share some updates and hear from several states that are leading this rural health system transformation. We'd like to start with a short update from Rifkin Friedman, the Director of the Division of All-Payer Models and the Acting Director for the Division of Population Health Incentives and Infrastructure at the Center for Medicare and Medicaid Innovation. Rivka?
Thank you so much for having me on this webinar and for your interest in the topic of rural healthcare innovation and sustainability. I am really happy to be here on the phone with you and have had many conversations with Rachel and her team about the work we're doing at CMMI in partnership with states to, among many other things, try to bring stability and sustainability to rural communities and their providers. So I am really excited to be providing this update today. First, just for the uninitiated, for folks not either heard of CMMI or worked with us, One of the many exciting things that we do here at the Center for Medicare and Medicaid Innovation is develop alternative payment models in partnership with states. Some of the most prominent alternative payment models that have come out of CMMI have been national models, things like the Medicare Shared Savings Program or the ACO program, Bundled Payment Initiative. Those are national models, and any provider can participate in them that meets the eligibility criteria. But in my division, we work one-on-one with states that are at the forefront of innovation in a variety of different domains in healthcare and are able to bring Medicare to the table for some of the most novel payment innovations at the state level. So you can see here on the slide 3 of the earliest examples of this work. The first, of course, is Maryland, which has the longest standing all-payer model in the country. And CMMI refined an alternative payment model with Maryland in 2014 and then signed a replacement to that model that just took effect this year, January of 2019, that puts the state at risk for total cost of care. So that is obviously very exciting work. Maryland has several rural hospitals that have been operating for many years now under global budget. And I think they were really the earliest use case for what a rural hospital and its community could do if they were able to pull away from the historical fee-for-service payment infrastructure. So that is really the seed of an idea that has since taken shape in a variety of different other places, most notably in Pennsylvania. And I'm so happy that we have Janice here to talk a little bit about the work we've been doing in the Commonwealth. Pennsylvania launched a model in partnership with our division in January of 2017 that offers rural hospitals there an opportunity to assume a similar global payment infrastructure. That model has been in pre-implementation for the past couple of years, and we are currently in the first year in which hospitals in rural Pennsylvania are operating under global budgets. So we have another set of use cases to examine as we think about the kinds of payment models that offer sustainability to rural hospitals and also offer a glide path toward value-based payment, knowing that the fee-for-service infrastructure has many, many challenges associated with it, in particular for rural communities. So with Maryland and Pennsylvania currently underway, we have been hearing from a variety of different states that have interest in replicating some piece of those two models locally. I think at this point we've spoken to about 30 states and representatives from those states that have interest in a model like this. We've spoken to individual hospitals, we've spoken to hospital associations, we've spoken to state Medicaid agencies, we've spoken to the governor's office and other political representatives and leaders. We've spoken to consumer advocacy organizations. We've spoken to many, many different kinds of organizations in a lot of different states that have an interest in new models of care and new models of payment for rural hospitals. So that is a pretty big impetus for the work that we are doing today, which you just heard the administrator actually announced publicly about a month ago at the National Rural Health Association conference. My team here at CMMI is putting together a national rural payment and transformation model that we hope to be able to announce more fully and share details about later in the fall. The model will be a national model. So unlike the models that our division has created to date, it will not be a model that we develop in partnership with a single state. It will be open to participants from across the country, like the other models that the center creates. And that is mostly because we have heard so much interest in payment models and care delivery models for rural areas. We want to make sure to meet as much of the demand for a model like this as possible across the country. The other thing to share, and I think the administrator mentioned this in her remarks, is that this is a unique model in that the participants are provider organizations, but they're also whole communities participating together. So, and Janice can probably speak about this, but the Commonwealth of Pennsylvania has had to do a lot of the work organizing hospitals in Pennsylvania, payers in Pennsylvania, other providers in Pennsylvania that might participate. And that work is very robust, even as the work facing individual hospital participants is also quite robust. And so we've been thinking about ways to formally recognize the fact that that is essentially a work stream unto itself and needs to be really owned and carried by an entity at the community level. We also have learned from our work in both Maryland and Pennsylvania that rural transformation is, a coalition of the willing. It requires stakeholders from across the board to be at the table, and it requires a degree of planning and coordination that we can't effectuate from where we sit at the federal government, and arguably that a single hospital or provider can't effectuate on its own. And so this model that we're developing really tries to hardwire the collaborative piece by bringing communities in as participants and having those communities represent a critical mass of payers and providers that might participate in the model. I think when the administrator mentioned this in her remarks, she said something like, I'm announcing this early because I want to make sure that I give stakeholders in all of the different rural communities across the country enough time to start organizing. So that is certainly one of the reasons that we've been talking about this model earlier than we normally would, because we recognize the degree of coordination and organizing, frankly, that will go into a given community and its providers and payers being ready and willing to participate. And so we're trying to get the word out early. A couple other key things to note about this model, and I think in large part these borrow from the series of action of Pennsylvania and of Maryland. The model that we're developing is trying to do two things at a high level. The first is create a more stable payment stream for rural hospitals and other rural providers. The challenges that we identify with the fee-for-service infrastructure are many, but certainly some of them are that rural hospitals under a fee-for-service system have incentives to grow volumes, and in particular to grow profitable volumes. There's no incentive to really manage a revenue base around sustainability because that's just not the way the payment incentive is structured. And so our hope is that by offering an alternative payment paradigm, we can enable rural hospitals and rural providers to shift away from the sort of fee-for-service growth necessary mentality and offer an opportunity to pull away from that and to try to do some what we call transformation planning around the future. The other key thing that we hope that the shift away from fee-for-service will enable is for hospitals and rural providers to focus not just on services that will grow the revenue base, grow volumes, grow profit, but services that may not be particularly profitable under a fee-for-service infrastructure, but that have historically been underinvested in rural communities, including primary care, including behavioral health, and potentially including telehealth-based services. So those are a few things that are very much top of mind for us and that we have heard many, many times in our conversations with rural communities across the country as key goals of this model: to increase access to primary care, to increase access to behavioral health, to enable rural communities to use telehealth at their disposal, to expand access to providers that may not be local in the community. So that at a high level is the first thing we're looking to do, is really change the payment structure. The second is to enable rural communities to focus on care transformation. So not just in terms of the way that they're getting paid changing, but in terms of the way that they're delivering care. We have had many conversations in both Maryland and Pennsylvania and also with states across the country, recognizing that there isn't always time or bandwidth to have conversations about what communities need that are currently underinvested, and there certainly aren't the incentives to encourage those conversations to happen. And so our second hope is that this model offers the impetus, not just the incentive, but the space and the resources to have some of those conversations that can encourage rural communities and their providers to transform care around key beneficiary needs that have currently not been met. We are very much looking forward to sharing more details about this model once we have them locked down and have gone through the proper clearance processes internally. Like I said, we're hoping to announce the model and share more details about it sometime later in the fall. And at that point, I would love the opportunity to come back and answer some of your more detailed questions about the model. But for now, I hope this was a helpful overview. And I will just conclude by saying, I know that all of you are on this call because you care deeply about the future of rural health and because you want to make sure that anything that we do here at CMMI and really elsewhere across the agency has in mind the goals of rural stability and sustainability. We are very committed to both of those goals. I know that Washington is too from my many conversations with them. So we hope to continue this conversation with all of you as our model development efforts continue.
Great. Thank you, Rivka, for that helpful update. We'd like now to hone in on Washington's vision for rural health system transformation with an update from Rachel Quinn, Special Assistant for Health Policy and Programs here at HTA.
Good morning, almost afternoon, and afternoon on the East Coast. As Michelle said, I'm Rachel Quinn, and I work at the Healthcare Authority, and I have been working on delivery system transformation, value-based models for the last couple of years, and have been working on our rural initiative for the last year or so, along with many of you on the phone, and many of you I know have also been committed to transformation with community partners through other avenues, and we really appreciate the innovative thinking and the forward thinking to think about how to improve rural healthcare and preserve access to rural healthcare. Today, I'm going to just give an overview of the rural model that we have presented previously. We have done some additional thinking here and there on it, but I wanted to just kind of do some level setting and then pass it off to Janice and Mike to talk about their experiences, which will be they're the first movers here, as Rivka said, and have been very great mentors to us as we've been on this journey. So I want to start out with the why rural, and I don't need to talk to you about the why rural and why now, because most folks on this webinar are the experts in rural health and are on the ground providing care or implementing policies that are affecting care in rural communities to date. But I want to call out that just in Washington alone, rural hospitals and healthcare systems provide care to over 1 million Washingtonians in parts of the state that would not have access to essential health services otherwise. Over the last couple of years, over the last 8 to 9 years, nationally and in Washington state, we've seen that rural health has, and these vital services have been at risk. We know nationally, probably close to almost more than 80 to 90 hospitals have closed, mostly in states that did not do Medicaid expansion. But we've also seen some closures in Washington state, even since 2010, even recently, there's a couple at really that are at risk. Currently, only 9, and the statistic might be more acute now. 9 of the 45 rural hospitals in our state are operating with a healthy margin, which is 5% or more, and 19 of these hospitals are operating in the red. Like Michelle said, due to population changes, declining inpatient admissions, other services that are more acute affecting rural hospitals are causing these financial problems, and we need to work together because, as Michelle mentioned, rural hospitals and health systems provide essential care, but they also provide a lot in terms of economic benefits to the community, jobs, and if that was to be dismantled, that would be very problematic, not for just rural communities, but statewide. In addition to those financial problems, looking at our data, rural areas also have greater healthcare needs and social and economic needs than urban residents. So the data shows some differences between rural and urban counties. For example, rural residents are often older and have a higher percentage of Hispanic and American Indian and Alaska Natives. A greater percentage of rural residents live in poverty with more unemployment and fewer years of formal education. A greater number of rural residents are in poorer health or have risk factors like smoking. And then there's also this aging. Someone said to me the other day they didn't like gray tsunami, but there's the rural areas definitely have a higher percentage of aging in their population, which is in Washington is the 8th most rapidly aging state, and so there is a lot of potential there to figure out how care can be redesigned to help that population in particular, as well as general populations and communities in rural areas. As Michelle mentioned, the Healthcare Authority, we are the biggest purchaser, but we wear a couple different hats. But as the largest purchaser of healthcare in Washington, in rural communities, by our estimates, we cover about 38% of Washington's rural population, and that is potentially going to be higher once school employees come under our hood or under our tent starting in January. So from the purchaser perspective, it is our role to ensure that rural residents we purchase care for have timely access to essential services. And in partnership with the Department of Health and our other state partners, the DSHS and the Office of Rural Health, it's our job to make sure, and we all have a vested interest in transforming to new models of care, as Rivka mentioned, in order to improve health outcomes for all Washingtonians and improve population health statewide. So this slide talks about our proposed vision and goals of the Rural Multi-Payer Transformation Project that we revealed and shared with state providers back in September. As I mentioned, and I'll speak to this a little further, that we've been in a lot of, since then, we've had a lot of conversations with payers, most of you, and others to get your input and try to fold it into this model, along with, in parallel, talking with Medicare to ensure the model meets their needs and requirements for Medicare participation. Our proposed vision is that by 2025, healthcare delivery in Washington's rural communities would be reorganized and transformed to match the regional health, social, and economic needs of their communities. Our primary goal is to sustain access to essential care in rural communities, and then our secondary goals are to improve population health and well-being outcomes and quality care for rural residents, incentivize rural health systems, which include hospitals, rural clinics, aging providers, accountable communities of health, tribes, and other rural providers and community partners to work together, to Rivka's comments about redesigning care for the community, not just one entity that meets the needs of their community, whatever that community population looks like, as well as in partnership with the state and the federal government and different public and private payers. We also want to improve the financial state of participating rural hospitals by realigning incentives and through care coordination. We want to decrease these disparities in these communities, not just health, but the social and economic disparities. And we also want to reduce the growth of total expenditures across payers. To do this, we have taken, as I mentioned, we have been watching closely of what Medicare is looking for to participate in a rural model and what they have looked at to participate under Pennsylvania and Maryland, and what type of accountability they need to see. As Rivka mentioned, it's not just about payment, it's also about kind of there needs to be two different components of a transformation model. Innovations that can be sustained through an alternative payment model, as well as a delivery system strategy that's going to transform the community. To date, we have been working towards an alternative payment model, a global budget for rural hospitals to join under this model, with additional incentives for different other providers outside the hospitals to incentivize coordinated care with the hospital. A community transformation plan strategy that hospitals and ACHs and other key stakeholders in their community would work together on to develop kind of more of the next stage of what a community needs assessment would look like, and then the quality metrics. As I mentioned, we have been working on this approach to align with Medicare because their participation is very key in terms of rapidly or accelerating transformation in these rural communities. As I mentioned before, HCA has about 30% covered lives in these rural communities. With Medicare, we're close to 60. So aligning with them, rowing in the same direction, and this, as well as other transformation efforts, has been a priority of ours as we move to more value-based models. This approach will bring stability and predictability for rural health systems. It allows for a customized approach for each community. It's an opportunity to address state and federal regulatory barriers, workforce, scope of practice, and then also as our accountable communities of health become more mature, it's a way for us to really marry social and address social determinants of health in a payment model. This slide, Rivka talked a little bit about the challenges, the fee-for-service challenges look different for rural communities, and especially with these problems that our fee-for-service system are more acute in these rural communities, decreasing revenues, increasing costs, and decreasing operation margins, and especially with the decreasing, as well as we move to more population health-based models and outpatient care and inpatient care is declining. On the right side is what a global budget, the attributes and what a global budget is aiming to do. It tries to infuse the right incentives into care, into a new delivery system model. Predictable, presents predictability and stable cash flows, and it provides incentives to invest in population and health. And the idea is that as you increase investments in population health, you decrease utilization and then hopefully more profits overall. This slide outlines what we've talked about to date of what the model, our proposed model would include. It's not a new slide. We have presented that the global budget would include, and this is a very high level wrapped kind of synopsis, and I understand some folks might want some more details, but at a high level, the approach would include inpatient, outpatient hospital care services, cost swing beds, other physicians, employed and unaffiliated physicians, as well as long-term care and behavioral health. Some of the tactical and technical details that need to be worked out, but this model would include adjustments for potential avoidable utilizations as a mechanism to share savings with payers and providers, and to be reinvested into care models, planned service line changes, unplanned market share shifts, and emergent issues exemptions. I'll talk a little bit about the timeline in a couple of slides, but you know, we also are, this model will include incentives related to care coordination, quality, primary care, and ensuring tight coordination with other providers in the community, as well as aligning, incentivizing partnerships with accountable communities of health. Again, we have, as we've developed this model to date, we've talked about, we've defined what a rural hospital is, what type of hospitals would be eligible to participate in this model. This model is open to all rural hospital health plans, as well as partners that work closely with those hospitals in this in rural communities, including patients, affiliated, non-affiliated providers, ACHs, public and private purchasers, and other community partners critical of transformation. This map shows, is not new to folks, but what hospitals would be eligible to participate under using the Office of Financial Management Rural County definition. In terms of next steps, we our anticipated timeline, as Rivka mentioned, to date we've had a lot of discussions with Medicare and CMI, and as they shift to more national model, we are shifting our timeline, and so I want to stress that this is anticipated timeline, that transformation is not going to happen overnight. We envision a multi-year model, 5 to 7 model with a phased approach. assuming that we're able to work with Medicare in the fall and early next year, that a pre-implementation phase would start in 2020, and potentially a budget could start for those early adopters in January 2021. Again, a lot of TBDs here, but this is the timeline that we have in front of us in place, and that we are looking to move forward on a model. In terms of next steps, we'd like to get your feedback on what we've presented to date, understanding that we've had conversations with many of you before. So everybody who registered for this email, you'll be getting an email asking you to answer some questions, and we appreciate in advance you completing the survey. And as always, please send any comments and questions to us at this email address, our Rural Transformation email address.
Great, thank you, Rachel. Nice overview. With this background, we'd like to transition to an overview and an update on Pennsylvania's rural health model with Janice Walters, the Chief Operating Officer Consultant for the Rural Health Redesign Office within Pennsylvania Department of Health. Janice.
Thank you so much, and I too want to thank you for allowing me to be part of this webinar today. My goal is to provide you information on what is currently happening in Pennsylvania, as well as kind of the journey along the way, understanding where the state of Washington is at, and the conversations that have been held to date. Hopefully can provide a little bit of insight into Pennsylvania's journey and everything that has went into getting us to this point, to have launched our program. So, as part of what I had been asked to talk about was really, the vision for transformation within the state of Pennsylvania. So if you could advance the slide to the next slide. So really, as has been talked about by Rivka, as well as Rachel, I don't think you're going to hear a lot necessarily new from me in terms of the vision for Pennsylvania, because it certainly has followed, what Rivka and Rachel have already identified. So really where we started in the state of Pennsylvania, the vision was twofold, with really two core tenets that would provide the financial, viability and stability, for our rural hospitals that they're currently not experiencing in the fee-for-service world, as well as transitioning them away from fee-for-service volume, to a delivery system and a payment system that actually rewards community health. And as we've been working with, a number of hospitals across the Commonwealth, in trying to reach our scale targets, I just want to share with you one comment that a CEO that is considering participation in year 2, a comment that he made. And that really was as he began to learn about the model and what we were, trying to do, and I would say the overarching goals of it. His comment to me was, this is actually going to provide the mechanism and the means for him as a hospital leader to actually go back to the days of what he felt the hospital was originally designed for. And that was, the community and the community's health. And in the current fee-for-service world, because of just the nature by which, we are looking to survive, it really is about, keeping volume in our hospitals. And that's not a criticism of anyone, that's just the current reality, because that's where the payment, is how the payment, methodology works. So for him, I just wanted to share with you, that's kind of a real life testimony of a hospital leader who felt this model in Pennsylvania was actually, allowing him to go back to why he got in the business, to begin with, and that was to take care of his community. So really here again, two tenets, not much different than what you've heard from Rivka or Rachel. It's really about providing a financially stable platform for the rural hospitals to allow them to actually reinvent and right-size their organizations in terms of what the community needs. So next slide, please. Just, kind of real quick, a visual picture of what a global budget is. We've actually put these slides together not only, to help inform such as this, but actually as part of our stakeholder engagement and our community engagement, as we went out and have helped hospitals, have this conversation within their communities and educating board of directors and all of that, sometimes it's really hard to wrap your head around what a global budget actually is. And so we put this picture together because sometimes a picture is worth 1,000 words. And on the left side of the chart, it's really the fee-for-service. And we all know that as, census and volumes decline in a fee-for-service world, so does the revenue stream for that local rural hospital. On the right side of the screen is really kind of the core of a global budget. So, we're using in the state of Pennsylvania historical net revenue to establish that baseline budget. In the absence of really anything else, that's what we're using. But once you establish that baseline global budget and you start moving into the future, as your volume and maybe service mix changes, your revenue is not, drastically or immediately impacted by that. And so it kind of just provides this visual picture that your revenue for the hospital is going to remain, consistent, even when volumes in your communities may continue to decrease, because of all of the issues that we deal with in rural America. So here again, the goal of our model is to keep the hospitals financially viable, keep access to healthcare in the local communities, because we all know of, the economic engine that all of our rural hospitals are, to the local community, but really providing, I would say, the impetus for change. And so, you're no longer having to focus on the revenue coming in, but you can really start focusing on the community, knowing what that revenue is going to be. Just another point I would like to make, a little bit different than maybe what Washington's proposal is at this point in time. I do want to bring out a difference between, Washington's proposal and the PA Rural Health Model. We are hospital only at this point. So, while Washington's proposal is more, I would say, across the continuum of care, especially for services, I would say owned at the hospital or health system level, we really are only including the acute care facility, so in and out, inpatient and outpatient, as well as swing bed for the critical access hospital. So any post-acute reimbursement or professional reimbursement, that's going to continue to be paid fee for service outside of the global budget. We are really looking to stabilize, the hospital revenue to ensure that access in the community remains as we build partnerships with, across the continuum. I think we all know that true population health resides outside the walls of a hospital, but we also know, the importance of that hospital in the local community. So our goal is to, provide that stability first for the hospital so that it can continue to serve as the convener as we move along the population health journey. So the next slide that should be in front of you right now is really kind of showing, the long-term vision, I would say, for the PA Rural Health Model. And certainly early on, our goal is to create financial stability for the hospital through that predictable revenue stream, to give them the ability to understand their revenues and then adjust the cost structure as may be necessary to create that financial viability into the future. But over time, as we start or we continue to work with the hospitals to understand what true transformation might look like in their communities, the thought is that over time, over the long run, we're actually going to be able to maintain revenue and have, I would say, a variance or a difference between the cost of care to provide that hospital service and the revenue. And then over time, how do they reinvest that, I would say, increased margin in the community for things that historically not have been a focal point for hospitals, such as, community health, walking, exercise, food, more of the social determinant, the broader social determinant of health issues that we all know need to be addressed. But quite frankly, if a hospital is struggling just to keep its doors open, it really has a hard time focusing on those broader social determinant of health issues that we know long-term will actually impact the overall, total cost of care. A great example, and I just want to tie back to something else that Rivka said, our hospitals are actively considering investing in things that traditionally have not been reimbursed well. A great example of that is pulmonary rehab. So I think everybody, or for the most part, anybody that's been associated with healthcare for any length of time knows, that COPD is one of, the largest drivers of, readmissions and, avoidable utilization and all of that. But historically, pulmonary rehab has not been reimbursed well in the fee-for-service world, and therefore, even some of the hospitals that we're currently looking to, onboard for 2020, they might have historically had that service, but because of the poor reimbursement, actually moved away from it. As we're starting to have these conversations about true population health, pulmonary rehab is one of those things that is coming back to the table, and there's active strategies because suddenly, the hospital, if they don't have to worry about necessarily their revenue coming in and knowing that they're going to actually be incentivized, to focus on the treatment of the COPD patient to reduce that avoidable utilization, they're looking to actually reinvest in that. So that's just one real example of, something that Rivka touched on in her presentation, and I just wanted to connect the dots that is actively happening in the state of Pennsylvania as, we're working with hospitals to develop their transformation plans. Next slide, please. So I think this slide is probably not new to a lot of folks. I know this has been, broadly shared, I think, as conversations have turned more to global budgets. But, within the PA Rural Health Model, there are really three ways that hospitals can actually, I would say, succeed in the model. And I'm going to direct your attention to the center, portion of the slide, A, B, and C. So A, reducing potentially avoidable utilization. So this is all about, identifying ways in the delivery system to provide, the right care in the right place at the right time. And so to the extent you have high, utilization in your emergency room, are there things that we can do to intervene there and actually reduce that to treat people outside of the emergency room? I know a lot of the people on the phone today are from small hospitals, and, our small hospitals, our rural hospitals, our CAHs in Pennsylvania are probably not a lot different from those in Washington State, especially as we talk about readmission and readmission rates. And, there's probably, to be quite honest with you, not a lot of opportunity for our hospitals, to, I would say, capture a lot of, savings or retain revenue associated with readmissions, because readmissions has been such a focus point just in, the healthcare delivery system now for a number of years. That I don't know, quite frankly, that we're going to have a lot of savings specific to readmissions. I do think, however, as we're looking at the data, for our own hospitals in Pennsylvania here, the emergency room is probably the greatest area of opportunity that we have for avoidable utilization and building delivery systems, to hopefully keep people out of our emergency rooms and in a more appropriate care setting. The next area is improving operational efficiency. So this is just good business principles and good business practices. You've got revenue and you've got expenses, and so you certainly need to manage your expenses as much as possible. Here again, I think a lot of our small hospitals and our rural hospitals in Pennsylvania, just in order to exist, have probably already done a pretty good job at improving operational efficiency. But we are working with our hospitals, all the same to identify, are there area of opportunities from staffing? Are you using staffing ratios? And, different, I would just say good business principles to manage your cost structure. And then the third area of opportunity is really optimizing that service profile. And here again, this goes back to, something that Rivka, shared earlier and stated earlier. It's really identifying the services that if you change from a fee-for-service world and, change that mindset from competition to community health, there may be things from a service line, profile optimization that you would want to reinvest in. And here again, that pulmonary rehab is a great example of this. A lot of our hospitals are looking to expand care management strategies, things that really are, I would say, more ambulatory care focused in order to keep those patients out of the hospital. There certainly is room for, optimizing service profile and, changing the services that the hospital delivers. But here again, the impetus behind that is the community benefit, and how do you, justify and validate that community benefit versus, fee-for-service revenue generation that in the current reimbursement arena we all focus on as hospital leaders. Next slide, please. So another area I was asked to kind of focus on today was, the approach that we are taking in the Commonwealth here as it relates to, transforming care. And so what we've actually put together, I would say, a longer term strategy, understanding that financial viability and creating that sustainability for the hospital is first and foremost, because we really can't expect our hospital leaders to focus on, community health and wellness if the hospital's not going to be there in the future, to provide services. So the financial stability has to be, I would say, near term. But then, we are using, measures that are, in the agreement between the Commonwealth and the federal government, health outcome and quality outcomes. Taking that plus our transformation planning priorities that our hospitals are identifying in their local communities. And together, that is building our multi-year social determinative health strategy. So we're using a lot of different inputs, and the hospital's transformation plan is certainly key to that, as well as measures in the state agreement, to come up with, I would say, our plan for the next several years in terms of how we really are going to work in the communities to impact, population health and community health long term. Next slide, please. So this is just kind of a further refinement of the preceding slide, and I think we probably all have seen the statistics out there that, only like 20% of a person's health is actually tied to the clinical care that they received. But, overall health is, comprised of a lot of different things. And, we've coined that phrase as social determinants of health. And so, somebody's not going to be healthy if they don't have adequate housing or if they don't have food. A lot of times in our rural communities, our population struggle with transportation. So the care might be available, but they have no way of getting, to that care. And so as part of our larger social determinative health strategy, here again, we've taken a phased approach to say, what do we think our hospitals can do near term? And then through community engagement and community partners, as has already been, brought out by, the former presenters, that this is not something that the hospital can do alone, that really to improve the overall health and wellness of the community, it really does have to be, a broad stakeholder engagement, and it has to be a community effort. So we really see as our hospitals, starting to serve as those conveners. I actually believe the state of Washington, based on some of the other things that you might have going on already, might be actually a little bit further along as it relates to community engagement and some community-based, population health efforts. So I think that bodes well for you. And one thing I also wanted to say specific to the transformation plans is we're working with our hospitals in the state of Pennsylvania here, and we asked them to put together their transformation plans. We're not asking them to reinvent the wheel. So to the extent they already have things identified in their strategic plans that are certainly population health aligned, we're encouraging them to align those activities and basically take credit for the great work that they're already doing, that the transformation planning process does not necessarily have to be over and above the great work that they're already doing. So it's just really important that I think going into this, that if you've already got great strategies that are happening, within your communities and at that community level, that the transformation planning process can actually just serve as a catalyst, to bring that all together and to, motivate and move the community forward for the overall benefit of the rural hospital. So here again, some of the things that we know we have to focus on in the out years. We're hearing this from our hospitals as we're working with them, and putting together their initial transformation plans. Probably transportation is probably the number one thing that we are hearing come up repeatedly that our rural communities struggle with, maybe even more so than housing and food security, but it really is that transportation issue. So I shared this slide with you just to, kind of set the stage that our transformation planning process is really taking a long view. In the short term, we've really asked our hospitals to come up with, 2 to 3 things that are really executable and that we can actually see, significant progress. Look for the early wins, but knowing that there's this longer view strategy that we will be looking to implement to truly, affect overall population health in the communities. Next slide, please. So as it relates to stakeholder involvement, here again, I don't know that I'm going to share anything really new with you, but just from a Commonwealth perspective, you know, the model did formally launch in January 2019, but there were a couple years worth of work that went into that successful launch. And probably the most important thing we did was stakeholder engagement. And here again, just to reiterate, you know, what we've already heard from Rivka and Rachel, it's really identifying the stakeholders and saying who within, you know, the community here within the Commonwealth did we feel like we needed to engage with in order to move this forward. So, you know, this list that I put in front of you is certainly not exhaustive. I'm sure I've missed some key partners, but it was really more just to show the depth and breadth of, you know, the stakeholders that it actually took to put this program together and to get it off the ground. So obviously we work with CMMI, but our governor's policy office has been very involved with this. You know, the Department of Health and the Department of Human Services in the state of Pennsylvania, that's actually two different entities, two different groups of people. Some states I know have that combined. In the state of Pennsylvania, it's two different groups. The Pennsylvania Insurance Department, so, you know, them being at the table with us as we approached our commercial plans to ask for their participation certainly helped in that conversation. Of course, the Hospital Association, you know, they are a key partner, as well as our Office of Rural Health within the state, especially as it relates to the critical access hospitals. You know, our program is for rural PPS as well as critical access hospitals. So we actually have 67 eligible hospitals in the state of Pennsylvania, of which only, I believe, 15 are critical access hospitals. So we do have a number of smaller PPS hospitals that are eligible for the program as well. But, you know, as it relates to flex and ship hospitals, our Pennsylvania Office of Rural Health has been just a very valuable partner, and actually has assisted, you know, in the recruitment of hospitals and getting hospitals, you know, to the table to consider participation. Of course, our hospital leaders, if we didn't have hospital leaders, we wouldn't have a program. So here again, this list is not in any way in order of importance either. Here, it was just a random list, but it's very, you know, if we didn't have our hospital leaders and our commercial payers at the table with us, we certainly wouldn't have a program. Legislators have been, you know, key partners, as well as other trade associations, you know, that we have within the Commonwealth. So here again, not meant to be exhaustive, but as you build your program, and here again, I know, you know, the state of Washington, you know, is further along than many states, but this is just, you know, kind of the breadth of the people that we've had to bring to the table and keep engaged along the way. And this list would now even be broader than that as we think about, you know, part of the role that we're serving here from the Rural Health Redesign Office is actually then identifying technical resources for our hospitals to actually help them implement, you know, their strategies. And so we're working with such folks as the Federal Office of Rural Health Policy, you know, and different, I would say, national level organizations to just help align the efforts, you know, for on behalf of our hospitals here in the Commonwealth. Next slide. So the current state, as I mentioned, we did launch the model with 5 hospitals in January of this year and 5 payers. Obviously, Medicare is key, one of the key payers, and then we also have 4 other commercial insurers, all based here in the Commonwealth. So we started with our state-based insurers, and now we are looking to engage more of the national level payers. When we approached our commercial plans and asked them to participate, we did ask that they would bring not only their true commercial volume, but also their Medicare managed care and their Medicaid managed care. In the state of Pennsylvania, Medicaid is pretty much all done through commercial or managed Medicaid. And so we've asked the commercial insurers to bring all 3 product lines and consider including them in the global budget. So we do have, you know, plans of expanding both our hospital participation as well as our payer participation. Our goal is to grow hospital participation to over 30 over the course of the next 2 years. and then increase payer participation to grow the global budget revenue. So our initial goal was to get at least 75% of the eligible net patient revenue for the hospital paid through the global budget. We're looking to grow that from 75 to 90%, and therefore we are approaching payers such as Aetna and United Healthcare to grow that participation. So I would hope that if we are successful in bringing them to the table for the Commonwealth, that they would also, and consider at least participation on a more national program. So hopefully some of the other states that embark upon this journey will reap some of the benefits of the groundwork that the Commonwealth is laying as it relates to, our national payers such as Aetna and United Healthcare. Next slide. Some of the key things that I think hospital leaders need to be considering, and just so you know, my background is hospital administration. I spent 12 years in hospital administration before joining, in this role as the Chief Operating Officer. 10 of those years were spent in a rural health system here in Pennsylvania. So I know very well what it takes to keep the doors open of a rural hospital. And so, I offer this to you, from, I would say, the lens of a hospital leader. So I think the first thing to remember is that change is hard, and it will require a different mindset. We've all pretty much been conditioned to the fee-for-service mentality, and, a global budget and community health does require a different mindset. And even though we know that the current fee-for-service structure isn't sustainable, and that we face a lot of risk in the fee-for-service world as it is, it's still very difficult to change from what is known. And so, here again, just don't underestimate how hard this change is and the different mindset that will be required. I was out at a board meeting a couple weeks ago. We provide, education for board of directors. And a CEO in that setting, would have looked at me and said, I think it's probably going to take me 2 years until I can actually probably think differently and move away from that fee-for-service mentality, because his whole career has been in fee-for-service. So I thought that was very astute on his part to recognize the journey and the retraining that he as a leader is going to have to undergo, if he would so choose to participate in the PA Rural Health Program. Also, the current fee-for-service structure isn't sustainable and will continue to be targeted from a payment reform perspective. So here again, as I stated, we already, I would say, are enduring a lot of risk in the fee-for-service world. I think this is a risk that hospitals run in the event they choose not to move or voluntarily participate in a new payment arena. Is, we know that the current trajectory of spend is not sustainable, and there is, a lot of focus at a national level in terms of the fee-for-service structure. And I don't believe that that is going to change. And so I think we just have to be realistic as hospital leaders to say really, truly, what is the future? If it's not a global budget, then what is it? As a hospital leader, you certainly have to weigh, the current financial position of the organization and weigh the risks of early adoption versus waiting. So here again, I don't believe the pressures on the fee-for-service payment structure are going to lessen. And so, if you choose to wait, you might actually have to endure additional cuts. But at the same time, you have to fully understand the risks of being an early adopter and what that means. I think you have to understand if there are other alternatives. So in the absence of a global budget, is there another alternative? I know for a lot of the hospitals in the Commonwealth, the only other viable alternative for them is acquisition, by a larger health system. A lot of our smaller community hospitals were built through community funds, and there is just a sense of pride and ownership of that local hospital, and a lot of our communities and leaders are struggling to hold on to that as long as possible. And so some of them are seeing this, global budget opportunity as a way that they may be able to remain independent. For some, that's viable. For others, just quite candidly, I don't know that the PA rural health model will be enough to keep them independent long-term. So from a hospital leadership perspective, it's like really understanding your alternatives, you know, in addition to maybe a global budget strategy. Also, I think it's important that you understand leadership's attitude toward population health. And so if your leadership teams, you know, don't buy into that or don't believe this is the wave of the future, you know, trying to change that will be difficult, and you certainly need that to be successful because you have to buy into both strategies. And I actually say that to the leaders as I'm out talking with them. It's like you have to buy into both parts, you know, the global budget and the financial stability and predictability, but also the commitment to transform, because our model includes both, and both are equally important. Also, I would encourage you to consider your culture of your organization and its readiness for change. You know, I think you would have a good sense in terms of how your medical staff would respond to something like this, or your frontline nursing staff, and just really objectively assess, you know, from a leadership's perspective, you know, the readiness of an organization to take on such a change. And then also competing priorities and the ability to implement. So here again, having been a leader in a small, you know, rural health system, usually the leadership teams are very, very lean. And so your ability, you know, to do this as well as, you know, other priorities, this goes back to the ability to align, you know, and not necessarily reinvent or come up with all new things, because most of our plates are already full. And to take on something like this, you know, you basically will have to prioritize in order to implement. And so, you know, I would say this really creates an opportunity to focus and make sure that everything that you are doing aligns with the overall vision of the organization. Next slide, please. So the last two slides, I'm certainly not going to share with you, but I was asked to touch upon like the value propositions. And so these two slides are basically content that we've pulled together, you know, since joining this initiative last June, and saying what are the different value propositions of doing the global budget or the PA rural health model through the lens of various stakeholders. And we believe these two documents, or these two slides, this one and the next one, really kind of capture what we would say the high-level value propositions are. There's 7 of them. And as we're out talking with different hospitals, you know, as we're, you know, recruiting them to consider participation, any one of these 7 can resonate, you know, with a leader. Some don't resonate at all. There might be 1 or 2 of them. But it's just interesting to see, you know, the different value proposition depending on where the hospital currently is at in the journey. I would also say that these pretty much resonate with our plans, our commercial payers. When we started pulling this together, we thought we would need a separate, you know, a separate deck or a separate slide, you know, one from a provider's perspective and then one from a payer's perspective. But as we've talked with both the commercial plans and our hospitals, we really do feel that there's alignment in terms of the current scenario and the desired future state, and then the value proposition that the model actually provides, you know, to the stakeholder, whether that's a hospital or a payer. You know, so, you know, whether it's, you know, unpredictability of revenue and moving to a predictable revenue stream, you know, that has value to both a payer and a hospital. You know, significant volume being driven by avoidable utilization. Here again, our plans have been trying to, you know, manage appropriate utilization for years. That's a lot of times where the tension lies between plans and providers is at the, you know, the payer, or excuse me, the payment for the service provided. We as providers try to, you know, qualify and say, you know, the care is needed. And the payers are trying to say, yeah, but maybe there is a more appropriate care setting, you know, observation versus inpatient, and that the tension that we have there. And at the end of the day, it really does come back to payment. Utilization being lost to tertiary centers. Here again, you know, under a global budget, you know, competition is no longer the driving force, so it kind of minimizes that. And then, some of our hospitals, in the Commonwealth, and I'm sure it's true there in Washington, you're already making significant investments in population health. And in the current fee-for-service world, you're not rewarded for that. You're actually de-incentivized. And this just completely aligns that. And here again, through our methodology, there's the ability, to go back and maybe recapture some of that historical revenue that was lost, through that look-back period. Number 5, next slide, please, just really quick. Sometimes our independent hospitals actually feel like they're islands under themselves, and they're trying to do things and they just don't have the economies of scale or the manpower to do it. And through participation in the PA Rural Health Model, we're actually creating what we call a cohort feel. And so through collaboration and partnership, they actually get the sense of belonging to something bigger than just them. Also, lack of technical resources and technical support. Through participation, we're able to provide some of that to them. And then, of course, stifled innovation just due to competing priorities. And through, model participation, here again, they're having that collaboration experience, as well as the potential, for waivers and stuff that might be prohibitive in the fee-for-service world. So that really concludes my formal presentation. I did leave some contact information, my contact, as well as I do have a colleague that serves as, the Director of Innovation that really helps and does a lot of the work with the hospital specific to transformation planning. But again, I just thank you for the opportunity to present this information to you, and I hope that you found it helpful.
All right, thank you so much, Janice. Appreciate the nice overview. Now that we've heard about where CMMI and Washington are examining and the experience from Pennsylvania, we'd like to review how some of this work has played out in Maryland's global budget model, presented by Michael Robbins, Senior Vice President for Maryland Hospital Association. Michael.
Thank you, and good afternoon, everyone. And it's my pleasure to bring you some perspective from the state of Maryland. What I'd like to do is remind folks to begin that Maryland is very, very unique in that dating back to the 1970s, the state of Maryland has not only had an all-payer hospital rate-setting system governing all of the hospital inpatient and outpatient revenues in our general acute care facilities, but we've also had a unique arrangement with the federal government through some form of a waiver. Again, initially starting in the 1970s with a waiver that was primarily focused on costs in the inpatient hospital setting. But what we've transitioned to first with our all-payer model, as Rifkin mentioned, that was adopted in January 1st of 2014, and that first demonstration completed just recently, December of 2018, and now in its current iteration known as the total cost of care model, which began in January 1st of this year, a model that is totally focused on healthier people and an economically sustainable healthcare system. If we can move forward a couple of slides, one more slide, please. Because what I want to impart with folks today is that if you look at the center of this diagram, while I do represent hospitals and while we are working with hospitals in all of our states, that at the center of this model is the concept of whole person care. It's not the providers that are at the center of this model. What we're looking at as hospitals to lead the effort for not only improving the health of the individual patient, their patient experience when they're within the four walls of the hospital, but we're also focused on providing accessible, convenient services in our community that will lead to long-term improvements in the health of the populations and communities we serve. And then ultimately also doing that at the most efficient, lowest cost per capita way possible. So if we can move to the next slide, What I'd like to talk to you is about the incredible risk that Maryland's hospitals are under this model for the total cost of care. Back in 2018, we estimated that Maryland's hospitals, under the demonstration then ended, would achieve about $138 million in Medicare total cost of care savings. That's not just hospital services, that's all services, including professional services and post-acute care. And it's Part A and Part B services. And drug costs are not part of that equation in the, if you will, the Part D Medicare costs. But we committed in this new model to significantly growing those savings for the federal government, so that by 2023 we committed to saving at least $300 million in total cost of care savings. And really the way that that's done is essentially meaning we calculate savings under this model by how we grow our Medicare total cost of care for all of those services more slowly than those services are otherwise growing nationally. So the risk here is if the federal government, if the national total cost of care growth slows down significantly, we have to beat that in order to generate savings. But more importantly, is in addition to generating those financial savings, there were very specific and aggressive goals for improving quality and improving population health. And I would argue, and I think our hospitals now clearly understand, that if we want this long-standing arrangement that we've had with the federal government to continue, that ultimately, while certainly making those financial targets are important, it's all about how we've improved the health of the population. That 5 years from now, when the federal government and the state and Maryland's hospitals and our other provider partners look at whether we want to expand or continue this model, we are going to need to clearly demonstrate what we've done to transform care, both within the four walls of the hospital and outside the hospital. If you could move to the next slide then, please, because truly this is all about moving from that fee-for-service to a value-driven system. And there are 6 aspects of the Maryland model that we believe are truly unlocking value for the Medicare enrollees. First, and we do, similar to the other examples you've heard, we do have global budgets. Those global budgets cover all of our inpatient and outpatient hospital revenue, and 100% of the revenues in those hospitals are under the global budget. We have a couple of freestanding specialty hospitals, our 2 psychiatric hospitals and 1 children's hospital, and a couple of rehab hospitals that are not under global budgets, but that revenue is a very small portion of the overall total revenue generated by Maryland's hospitals. As I said, we also have had this all-payer hospital rate setting system. So unlike the Pennsylvania model, all of Maryland's payers, Medicare, Medicaid, all of the commercial payers, by law, have been committed to being paid and having rates set by our state rate setting commission. We have been exempt from the Medicare and Medicaid programs nationally under some form of our waiver going back to the 1970s. And one of the interesting things under those all-payer hospital rate settings is that we have been able to equitably share the costs of uncompensated care across all payers. That's a unique feature of our model, but we think one of the endearing features of this model in that we, across the state of Maryland, are committed to making sure that all of those costs are being covered within our rate structures. And in that way, every hospital, in essence, serves as a safety net provider because Maryland citizens can go to any hospital and receive care. We don't have any safety net hospitals that you may find in other states. There are certain aspects of this model where there is accountability for the Medicare total cost of care through an attribution process, a very challenging process for hospitals to understand, but that's another way in which Maryland's hospitals are held accountable for the Medicare total cost of care. But more importantly, one of the features of having a demonstration and the arrangement with the federal government through the demonstration authority of CMMI is the ability to design programs. We call them in Maryland care redesign programs under a model that is approved by CMMI that allow us to align care with our non-hospital providers. Because on a day-to-day basis, the greatest challenge with having hospitals under global budgets, but all other providers who are not, and all of the payments that are still in the fee-for-service world, is how we align our work between the hospitals and our community-based providers towards the goals of this total cost of care model for improving health. And again, we have some very specific population health goals. For example, we have chosen as the first major population health metric to be measured is what we're doing to reduce the incidence of diabetes in the general population, not just for Medicare, but across all payers. And the programs we put in place, we know that as we improve on the incidence of diabetes in the population today, that will help us to avoid the actual cases of diabetes for that Medicare population 15, 20, 30 years from now. Finally, and this was true under our all-payer model that started in January of 2014, real incentives for hospitals to improve on the quality of what's taking place within the four walls of the hospital. In the first 5 years of our initial demonstration, Maryland's hospitals, which probably ranked first or second worst in the country on our rates of Medicare readmissions, were able to successfully reduce that using the incentives on our global budgets and working with our community partners to the point where by the end of those 5 years, we were slightly below the national average for that Medicare readmission rate, and we need to continue to improve that success. We also reduced through our own hospital-acquired complications program the rate of those conditions by over 50% during that first 5 years. So if we can just move to the next slide again, the incentive is to avert avoidable hospital use, to take the savings within the global budget, reinvest them in prevention, and to maintain, if not, and certainly improve and uphold our performance on these quality metrics. If I can just go to the next slide. Again, I just also want folks to keep in the back of their mind that we have had this unique all-payer payment system where essentially compared to the rest of the country, Medicare and Medicaid have been paying hospitals in the state of Maryland more than they would otherwise be paid in the rest of the country. And in return, we have significantly less cost shifting, very little cost shifting. We adopted Medicaid expansion and it developed our own health insurance exchange back in 2014. So we now only have about 4% of our hospital costs that are for uncompensated care. And so there's a little bit of a cost shift, but much, much, much less than what you find in the rest of the country. To keep that arrangement, we clearly have to demonstrate to Medicare and to the state that we are doing things to transform the delivery of care, improve the health of the population, as well as demonstrating the savings. If you skip ahead to the next slide, please. I think the focus here, and this is the toughest thing for, I think, folks who look at this model to understand, is that while we are trying to drive care to the most appropriate setting, and by doing that, we can generate savings within the global budget, one of the things we need to remember is that you generate those savings by essentially being able to eliminate at least the variable costs associated with those services that you are moving to the alternative setting. And I will just say up front that that may be more difficult to do in a critical access hospital where a much larger percentage of your costs are fixed than you can in, say, a large urban hospital or a larger rural hospital where perhaps there's a different fixed cost, variable cost relationship. But to the extent that we are generating those savings, hospitals are investing those resources in bringing better access and care outside the four walls of the hospital and working on partnering with folks who have been there all along but may not have worked closely with hospitals in the past. That is one of the true values of working under this model, is the partnerships we've built up for success. If I can turn to the next slide, and this is where I wanted to talk again about one of the features of how we do a provider alignment and how we try to align our incentives between the providers who still remain in the fee-for-service setting versus the value-driven model that we have and the incentives that hospitals have under the global budget. And what we have added to the global budget model under the approval and guidance of our federal partners at CMMI are 4 different care redesign programs. The first, known as the Hospital Care Improvement Program, is focused on working primarily with specialists in the hospital setting on improving the efficiency of the delivery of care within the hospital setting itself. The second, known as the Complex and Chronic Improvement Program, also went into effect about a little over 2 years, almost 2 years ago, and that's focused on working primarily with primary care providers on sharing resources and information, and in both of those models, associated with having this approved as part of our demonstration, CMMI is able to provide us, CMS is able to provide the state of Maryland and the hospitals and physicians who are eligible and sign up for participation in these specific programs, enable us to provide gain sharing with physician providers, a waiver to be able to share some of the savings within our global budget with those providers. That's one of the financial incentives that we can offer for physician providers working with us on the redesign of the delivery of care and getting our patients into the most appropriate setting. A third program which just went into effect is designed to partner with post-acute providers, known as the Episode Care Improvement Program. If you're familiar with the post-acute care bundled payment for care initiative nationally, designed almost identical to that program. And finally, the last piece, again, which just went into effect this year with our new total cost of care model, the Maryland Primary Care Program. If you're familiar with the CPC Plus model that Medicare has put in place in a number of areas throughout the country, this model was designed very similarly to that model. This is a model that actually brings in additional new resources to our primary care providers from Medicare to transform the delivery of care in our primary care practices, here, for example, a lot of promise about bringing behavioral health care resources closely to the patients in those practices, transforming how they deliver, who their partners are. Too early at this point to talk about how well these last two programs are working, but all of these care redesign programs are designed to align primary care and other providers in our community with the goals of this new model. And again, if I just turn to the next slide, just one last point again about population health. I've listed here some of the things that we're doing. We actually, in doing that financial calculation about Medicare savings, have submitted a proposal to the federal government that would allow us to get credit towards those savings for the improvements we're making in improving on these population health outcomes. Very sophisticated actuarial calculation, but it's a way in which we begin to move the focus from outside the four walls of the hospital and again to truly improving the health of all patients in our community. Let me then skip to the very last slide. I'll skip over this next slide because I want to make sure we leave enough time for your questions. Ultimately, for this model to be successful, we know there's only so many resources that we can provide to hospitals through our hospital rate regulatory system. There are strict requirements on how much we can allow hospital revenues to grow on an annual basis under this model. So we need to work closely with a whole range of community providers working on, as we've talked in these earlier presentations, on the social determinants of health. But we know we as hospitals cannot finance all the costs needed to be successful under this model. We need other providers, other payers, and in particular the state to come to the table. So we've set up a work group with state leadership looking at, for example, how we can begin to restructure or invest within the state's budget around affecting these social determinants of health that have so much of an impact on our overall population health. So, for example, where we talked earlier about having to attack transportation, we're asking the question, when the Department of Transportation, the State Department of Transportation, puts its budget together, can they identify resources or opportunities to invest in non-emergency transportation to help our Medicare enrollees and Medicaid folks to get to their appointments in time so that we can avoid their use of hospital emergency rooms? Are there other things that we can be doing in the area of housing using supports from the state budget process? So we need to clearly work closely with a range of new partners that, while they've been there, we know this system has been so fragmented. This is all about bringing all of these resources together and working for the goal of improving the health and well-being of the populations and communities we serve. So if I can, let me stop there. I know I could have spent about an hour just talking about how we build our global budgets, but I'd like to see what questions that folks have. Rachel? Michelle?
Great, thank you, Mike. We'll now shift gears, and I'll turn this over to Gary Swan, our Senior Health Policy Analyst, to work through some of the questions that we've received. And I'll remind you again that if we can't get through them, that we will post answers afterwards. So, Gary?
That's great. Thanks, Michelle, and thanks for all our presenters for joining us, for those participants who joined us for this conversation. We have several different questions. First question relates back to how this model will work with our accountable communities of health. I'll start in. I think that it's going to be vitally important to have this work sync up with our accountable communities of health. As everybody knows, we have dollars for projects through our accountable communities of health, and there's been a lot of kind of regional planning around those efforts, many of which those plans have been developed in great detail with you all as participants. As we go forward, I think the kind of layer down on that is starting to localize that in a little bit more of a direct fashion at a local hospital level, and identifying those opportunities where we can better coordinate and create more robust kind of outcomes at a local level and addressing those local level needs, kind of in alignment with our accountable communities of health. I don't know if there's any other comments from those participating, from Rachel, Michelle, and I don't know if Judy is still on us, but on the phone, but welcome other comments.
I would just add, because I work on a variety of value-based payment and value-based care models, transformation projects. We have, the Healthcare Authority has built the ACHs through, well, starting with our State Innovation Model Grant, and then really kind of ramped up under our Medicaid Transformation Project. But it is our intent, the Healthcare Authority's intent and expectation that ACHs will play a major role in being that vital community clinical linkage in various communities across Washington, and that we intend through our different payment models, including this, and future ones, that ACHs will play a big role in facilitating those conversations and connecting social and all the different, being the locus of stakeholders in various communities across the state.
Thanks, Rachel. I'd like to address the question a little bit ways down. You know, we welcome CMS on leading on a national model. I think there's questions and interest around what that means for the investments that we've made thus far in a state-based model. I'd say that the efforts that we've made thus far, one, will contribute to kind of the input from states and the early development of any kind of model that comes from our federal partners. But also, as they go through and identify what that overarching model will be, there are Washington state-specific interests that I think that we have learned through that engagement process, and things that we'll be certainly advocating for. But we also recognize, and I think our federal partners recognize, that there needs to be a lot of state flexibility in implementation, especially on models of this scale. So while they kind of lay down the rules of the road in terms of the overarching framework, I think that there's going to be a lot of flexibility within that framework for us to operate in. There's another question here on, you know, really relating back to the deficits that some of our rural hospitals experience, particularly on our public payers, Medicare and Medicaid, through our hospitals, and how were we to kind of reinvest those in primary care with those you know, current operating deficits. So I think part of the opportunity under this kind of model is that it is, you know, it's a revenue play. It stabilizes that revenue, recognizing that there are thin margins in our rural providers, but it puts some predictability to that stream of revenue. I think that on the longer term, and this kind of gets back to lining up with our accountable communities of health and identifying other opportunities. If there are opportunities from a state level to invest in that care transformation, as interest from, you know, our legislative oversight. I think we've also been seeking, you know, alignment and opportunities from our federal partners, but I think that the deficit piece of this really is around how do we stabilize the current system as it is, seek and align with the investments that we've made thus far to better accelerate that change. And if there are opportunities from our federal partners or from a state or local level to think about reinvestment in a different way, seeking those resources out. And I think that'll certainly be part of the conversation, is kind of the capital investment on the upfront has been, I think, recognized both by state and brought to our attention from, you know, all of our partners. So I think that's going to be a fundamental question that we're going to need to address in one way or another. But I do think that once we kind of transition to a new kind of model of care. It shifts how we approach those capital investments at a community level, at a local level, and starts to change how we engage in that conversation for how we are seeking those dollars and seeking that reinvestment. So, for example, of taking bonds or other kinds of local level kinds of investments, or entering into regional partnerships, it shifts the conversation about how you're using those dollars and using them for population health. We have a question relating back to social determinants of health and the role of the hospitals. So for Mike and Janice, also potentially Sule, how have social determinants of health and approaching that worked in either Maryland or Pennsylvania?
This is Janice. I can take a stab at that first, and then, punt to Marilyn. So really, as we're working with the hospitals, we really can't, I would say, until you know what the social determinant of health issues are, you really can't address them. So, as a starting point, as we're working with hospitals, to put their transformation plans together and start implementing changes in the early, part of our model, we're actually using it as a data gathering and starting with data gathering, specifically focusing on those, I would say, high utilizers, and trying to identify, what maybe the social issues, or if there are social issues that are driving that utilization. So, from a very practical starting point, we're using, tools, specifically, evidence-based tools. And as providers are interacting with patients, asking them to fill out like survey type information that just identifies, for example, do you have food to eat? And basic, social determinant of health issues. So really just data gathering and using that as a starting point, that once we have data, then we can use that to inform, transformation plans and action steps in future periods to address those social determinant of health issues.
And let me take up for Maryland. A couple of things I'll point out is one of the things that is critical to the success of any of these models is just that, having the data that you can analyze to understand what your opportunities and needs are. And so as one example, and in part because we have a very successful statewide health information exchange that all of our hospitals and most of our other providers participate in. One hospital, for example, was able to determine that many of their emergency room admissions were coming from one particular zip code, and in fact one particular housing complex in their community. And what they were able to do is identify that if I took some of my global budget savings and put those savings into establishing a primary care presence in that location, they could reduce, if not eliminate, most of those unnecessary emergency room admissions, generating further global budget savings that could then be used to expand on greater investments in those kinds of social determinants of health. That's on a little bit more of a hospital-wide basis, but we had one example we always like to quote about a hospital that noticed that during the summertime they had a number of pediatric asthma patients who were coming into their emergency room several times a year during the summertime. And what they did was they took a nurse and had that nurse go and visit the patient's home and determined that they did not have adequate air conditioning. They had no air conditioning in that home during the summertime. And so the hospital used some of its global budget savings to purchase an air conditioner for that particular patient and their family. and able to avoid then those pediatric asthma admissions coming into their emergency room. Those are just a couple of small examples of the things that you can do to address the social determinants of health when first you have the data to identify those hotspots, and then second, as you begin to generate global budget savings under the model, to use those savings to invest in the needs of the community outside the four walls of the hospital. So that's a couple of things we're able to do. Now, there's a lot more that needs to be done than just those couple of small examples I gave, and that's why I talked earlier about needing to find other sources of funding, because you don't generate all of the global budget savings that you may need to address all of those social determinants of health within just the global budget.
Great. Thanks, Mike. Shule, did you want to make a comment?
Yes, thank you. And after the two comments, there's not much to say, but just to tie those two together, the concept of the global budget is really focusing on root causes of the utilization rather than disease-specific interventions. You know, there is a lot of work have been done already on the disease-specific interventions, and as you know, not a lot of them are successful, and the ones who are successful really focuses on social determinants. So in those two comments from Janice and Mike, you'll see that what they are looking at is looking at your data and then figuring out what is really the root cause rather than the symptom, which is the disease, that what we've been trying to do all along. And starting small and just understanding the input files and focusing on certain conditions or certain COPD or asthma is a way to go, but then from there quickly realizing that the interventions really have to be more community-based is, I think, a lot of the hospitals have done in Maryland and in Pennsylvania. That's what they've been focusing on as well.
Thank you, Shule. We have a comment, you know, recognizing that our critical access hospitals, at least in Washington State, are paid and costs on Medicaid and Medicare. Questioning why this might be a better option for those hospitals. You know, I think in the broadest sense, to some of the comments, or one of the comments that Janice made early on, is that, you know, this is an opportunity to really kind of rethink how you're delivering care in your rural community. The critical access hospital system, I think, has been, you know, very necessary in a historical context of making sure that we provide that care and making sure that we have adequate access, but it is a potential limiting factor if you're trying to redesign care. I mean, in essence, the system is still incentivizing around driving that historical inpatient utilization where that may or may not necessarily exist. So I think it'll be a question for the local provider to determine whether or not this is a good opportunity to participate, whether it makes sense based off of where, you know, kind of the economies of your local system are and what the needs are of your community to participate in this payment methodology. But fundamentally, this is really around starting to get towards some of that broader community health and then get rewarded for that as you start to transform your delivery system. I don't know, Janice, Mike, Shule, if you had any additional comments you'd like to add?
I think you said it very well.
Agreed.
There's a question on the care delivery design plan and how it's going to work with the CMMI proposal. I think that that's going to be very much driven by the local community. I think that there's going to be clear outcome expectations that we're going to want to see, both from kind of the state level and the feds are going to want to see. But it's going to be a partnership between the payers and the providers in discussing what that care redesign might look like and how we can establish the right revenue streams to make sure that that is appropriately funded and meets our care delivery transformation expectations. So I think there's going to be a lot of flexibility in how we approach that, and we'll be guided again, by this broader strokes that our federal partners release. There's a question around what a definition of rural is. So Rachel mentioned it earlier on. Right now, we are taking the kind of broadest definition of rural, and we're looking at our critical access hospitals. Either your critical access hospital or are in a OFM rural designated county. Those are listed on slide 14, and we can follow up with a kind of a complete list. But if you are a rural provider in a rural county, OFM rural county, or you're a critical access hospital, you'd be eligible for this model. The follow-up question really is, we focused in this conversation on the hospital, but really are looking broader. The question of whether or not this applies to our federally qualified health centers and how they might fit into this. We've invited our accountable communities of health and our federally qualified health centers, as well as our rural health clinics, to this presentation. So I think it's going to be critical, in particular, when we're thinking about this care transformation plan. This transformation isn't done in isolation. We're looking at broader swaths of services than Pennsylvania, and I think Maryland is approaching where kind of more aligned where we're hoping to head with inclusion of primary care, as well as eventually starting to bring in some of those specialty kinds of things. But our federally qualified health centers and our rural health clinics right now are the existing infrastructure in our rural communities on how we deliver a lot of that primary care. In particular, dental services and behavioral health services. I think that there's a lot of other kinds of pieces that are kind of existing infrastructure. So when we're talking about a care transformation plan, or you're talking about transforming it in our rural hospital, we want to capture from a perspective of that rural community as much as possible in that care redesign strategy. I think we've started looking at starting with the rural hospital as kind of the economic center or the economic hub of our rural communities, kind of stabilizing our rural hospital, but really starting to think a little bit broader than the straight inpatient, outpatient services that are delivered in that community. So there's a question around hospital designation and shifting. Again, it'll all come back to whether or not you're in an OFM rural county or you're a critical access hospital designation, at least at this stage. That may be informed further by our federal partners, but that's what we've advocated for at this point. So if you're a part of a larger system or a larger network, you'd be able to participate. That site would be able to participate in the same methodology. I do have a question on kind of this return on investment kind of question. So, Mike, I know you've talked kind of extensively about how providers are thinking about that care, but how has the return on investment calculus, or what has the conversation been, if you're aware, with our rural providers in Maryland as they think about how they're tackling, what are those kind of investment strategies to manage under that global budget?
I guess there's not an easy answer to your question, because I sort of asked first, what do you mean by return on investment? What I can say, for example, is that to ensure that payers receive a return on the investments that hospitals are making in population health and the savings that they're keeping within their global budget, there is a process that the Rate Setting Commission goes through in updating hospitals' rates every year, where a portion of those savings are actually shared back with all payers through what we call a shared savings percentage. So instead of getting, let's say, a 3% rate increase, the average hospital might get a 2.7% rate increase, so that a portion of those global budget savings are shared back with payers. So hospitals then need to figure that return, that savings sharing, into their return on investment calculation. But more importantly, I think, is the return on making the investments in making sure the patient has access to care in the most appropriate setting. And I don't know that you can necessarily put a value on that. Clearly, coordinating care, eliminating the fragmentation of care, getting patients access to care as close to their home as possible is what we're all about in this process. And I, again, don't know that you can put a specific value to that, but that is clearly the commitment that our hospitals have made in buying into this program. So maybe if that's not specific to the specific answer folks are looking for, I might just need a little bit more specific specificity of the question.
Well, thank you very much. We appreciate your time today. Again, this webinar has been recorded and we'll follow up afterwards. We ask that you please complete the survey following the close of this webinar, and thank you for your participation.